Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. In this episode, we hear from Dr. Coleman Smith and Dr. Lydia Tang as they discuss how to screen for hepatitis D virus and also discuss strategies to increase HDV testing rates. To follow along with the slides, visit the link in the show notes for this episode. So let's get started and hear what they have to say about screening and testing for HDV.
My name is Coleman Smith. I'm a hepatologist at Georgetown University, and I'm going to review some slides talking about how to screen for hepatitis delta virus. And I'll be joined by my colleague, Dr. Lydia Tang from the University of Maryland. Okay, so let's start. Firstly, the HDV is a simple virus. It contains a specific HDV RNA virion, and the surface of the HDV virion is in fact the hepatitis B surface, contains HBsAg. This compares with the somewhat more complex structure of the hepatitis B virus. So we have an algorithm for the evaluation of HDV. In patients who are HBsAg positive, they should be tested for the anti-HDV. And if that's positive, they should go on to be tested for the HDV RNA. If that's positive, they should then be tested to assess the degree of liver damage, measuring ALT and various tests for liver fibrosis, which I've outlined there. If they're negative at any of these stages, then they should be managed as the standard of care for HBV monoinfection. And here are the tests used for diagnosing HDV. Firstly, the HDV antibody, which I've suggested is the screening test. This usually appears 4 to 8 weeks after an acute HDV infection, and because of this, you may need to test serially before it becomes positive. And as I said, this is used as a screening marker for HDV infection. The IgM anti-HDV can be present in acute and in chronic infection, and the IgG antibody, not available for clinical use, but is present transiently in the acute infection and may be present in the chronic infection. I don't use these very much because they don't sort of tell us much more than the total anti-HDV antibody. HDV RNA is the confirmatory test. It's a sensitive assay, and the quantification varies between assays because of the heterogeneous nature of the HDV genome. So different assays may give you different sensitivities. HDV antigen is not used very much. It's present transiently in the acute infection, but it's often not detected in the chronic infection because of binding with immunoglobulin. And Dr. Tang, do you have experience in using these tests? Are they available easily in commercial labs, or does it need to go to special labs in your experience?
It's mostly available commercially for us. I've never had an issue getting the antibodies, the anti-HDV antibody, a total antibody, just through commercial labs. The RNA testing, now that is something that I actually have not really obtained routinely commercially. However, I do also work at the Veterans Affairs, and we do get those done routinely here as well. So I think it is fairly easy to access the RNA testing. The others, though, not so much. Those, I really just look at the total antibody and the option of the RNA testing.
Yes, I would agree. I think they're the two ones that are, from a clinical point of view, are most relevant. And we have a serum markers of acute self-limited HBV-HDV infection. In most cases, these various serologic markers and nucleic acid testing will actually dissipate and the virus will clear. Occasionally, it doesn't, but in most cases, this is a story that we see. Acute hepatitis B HDV infection will get better. And in my experience here in the US, I see this very, very infrequently. Dr. Tang, you had much experience, much exposure to seeing people with an acute HBV-HDV co-infection.
Very few, very little experience. I think it comes down to most people are asymptomatic, or they're in that sort of very mild symptom range, and so they never really present to us acutely, right?
Yes. And what happens for HDV superinfection of a chronic hepatitis B infection, which is more the clinical picture that we see here in the US, and I think in lots of other places as well. In the panel on the left is the usual story where things persist. HDV RNA persists, transaminase elevation persists, and you can still detect antibodies. The panel on the left is less frequent, but this results in clearance of the hepatitis D. Note, however, that the HBsAg persists. So in other words, the D antigen or the HDV infection comes and it goes. That's fairly uncommon. The usual story is we see, as on the left side, both the D and the B persist. Dr. Tang, your experience would fit that as well?
I definitely agree. It's certainly unusual when I do identify people that are HDVs, a Delta virus antibody positive, for them to subsequently be RNA negative. Not to say it doesn't happen, but the majority do go on to develop chronic infection.
So in the different stages of HDV infection, I've just summarized the different markers. You'll note that hepatitis B surface antigen is positive throughout. In the acute HBV infection, the IgM is positive, less so in chronic hepatitis B infection. The serum HD antigen, which we use very infrequently for the reasons that you can see in the slide, in the acute infection, it's early, it's short-lived, often missed, and in acute HDV superinfection on a chronic B carrier, it's once again transient and often missed. And in chronic HDV infection, for reasons I mentioned before, because of the fact that the D antigen combines with immunoglobulin, it's often not missed. So once again, not a very useful test. The serum HDV RNA is positive in all of these circumstances. The anti-HDV total is positive in all of these circumstances, but in the acute infection, it may occur late and at low titer. In acute superinfection, it rises, and in chronic HDV infection, it's usually present at high titer. The anti-HDV IgM, which once again, as we mentioned, is not usually used because it's clinically not all that useful, is positive in all cases, both acute and chronic. So as well as assessing the hepatitis D virology and the presence of infection, we always have to assess the degree of liver injury. And we commonly use transaminases, and the ALT is the one that we often use, and this is used to assess necroinflammatory activity. We also need to know how much liver damage is done in the terms of fibrosis. Have they progressed to cirrhosis? And here we've got a number of different assays we use. There are various serum fibrosis markers. There is things like APRI. There is things like the FIB4 test, and there's various commercial assays as well. Liver stiffness measurements can be done using a FibroScan, using MR elastography, and so on. These will tell you how much fibrosis there is in the liver. They're non-invasive. However, they do have a lower performance accuracy in chronic HDV versus hepatitis B monoinfection and HCV. And then, of course, the gold standard is the liver biopsy. This will assess both necroinflammatory activity, ongoing activity, and degree of liver damage in terms of fibrosis. The limitations of this are the sampling error, and most importantly, it's an invasive test. So, Dr. Tang, what, in your experience, how do you usually assess patients, the degree of liver injury in patients that you have with the chronic D infection?
So I keep it very simple, and I have a huge reliance on checking ALT and doing FibroScans. I like doing that because we have the luxury in my clinic of either just a very limited number of people doing the FibroScans. So, we get pretty consistent readings on them. And I like to be able to kind of serially monitor things. I certainly see the serologic markers and the calculations being utilized in facilities where they don't have access to the FibroScan. But if you have access to the FibroScan, that's my preference.
Okay, thank you. So one of the things that happens in hepatitis D is an increased risk of progressing to more severe liver disease, cirrhosis, and an increased risk of progression to hepatocellular carcinoma. And from the AASLD guidelines, recommendations for HCC screening in patients who are hepatitis B carriers, patients with cirrhosis, patients who got first-degree family members with a history of HCC, Asian or African American men older than the age of 40 or Asian women older than the age of 50 have a higher risk of HCC. And most importantly, patients who are co-infected with hepatitis D have a higher risk. And the recommendations based on these guidelines are 6-monthly screening with ultrasound with or without alpha-fetoprotein. And the important thing is, regardless of the status of their hepatitis B, whether it's suppressed with medication or spontaneously, screening for hepatocellular carcinoma should continue. Once again, Dr. Tang, your experience with screening of these patients in your institution, is this something that's commonly done?
It's something I think that across the board can be improved upon. And I wonder if it is related to just the additional complexity of having to get that ultrasound done, right? So you have to make that appointment and go to the other facility, get the ultrasound done. And also, an ultrasound every 6 months is fairly frequent. But, we strive to aim for that. And it's something, we always recommend. But I feel like, if we could at least get a year in an annual ultrasound, is better than nothing. But it's definitely something I think across the board can be improved upon.
I would agree. I think there's data out there suggesting that our ability to follow these recommendations is very limited across all types of institutions, academic, private practice, and so on. So yes, this should be improved upon. So we're going to have a look at a clinical scenario. The patient comes into the provider and they're tested, they're at risk for hepatitis B, they're screened, they get positive for hepatitis B. The next thing that happens is an appointment is made to come back and see them to review the testing, and then they're then sent for, according to our guidelines, for hepatitis D testing. So off they go to the lab, get the hepatitis D testing, appointment, come back to the provider, check the results. The antibody is positive. Let's get an HDV RNA. Off they go to the lab, come back to the provider, and then the provider sees them. It's got all the data and now suggests appropriate management. So in each of these steps, there is the opportunity to be lost to follow-up. And unfortunately, I think we do lose patients to follow-up. The more steps involved, the more appointments with labs coming back to the doctor, they're more likely to be followed up. So you see a suggestion that can limit the opportunities to be lost to follow-up. Patient comes in, gets their hepatitis B testing, and if they're positive, the lab will reflexly test for hepatitis D. Now, if the antibody is positive, they will reflexly test for HDV RNA, and then the patient can come back to the doctor. So there's eliminating many steps where there's ability or an opportunity to be lost to follow-up. Dr. Tang, any comments on that from your point of view?
No, I think it's so reasonable to do the that reflex testing for the RNA, and we know that works from the hepatitis C arena. That it makes a big difference, and just cutting out that extra step as well. And your patients appreciate it too. Just one less lab visit, a bit of less blood drawn. So it just seems so logical.
Yes, I would agree. This was a study presented or published from 2 centres in London, where they looked at reflex testing versus provider discretion testing. And you can see the number of people that were tested for HDV when reflex testing was employed was almost 100% compared to less than half when provider discretion was employed. And that then led to the appearance of a number of patients who are anti-HDV positive who would have been missed where provider discretion only was employed. So this is a small study which demonstrates over a prolonged period of time that using this reflex testing will end up picking up more cases than we would otherwise. And in summary, the take-home points. All persons testing positive for HBsAg should be tested for hepatitis D according to that screening algorithm. Patients co-infected with B and D should receive ongoing monitoring for liver damage and HCC, since they experience more rapid progression and more likelihood to develop liver cancer than those with HBV monoinfection. Reflex anti-HDV testing and other strategies should be employed to increase HDV testing rates and reduce loss to follow-up in persons positive for HBsAg.
Well, thank you very much to Dr. Smith and Dr. Tang, and thank you to our listeners for joining in. To view the full program on the Clinical Care Options website, click on the link in the show notes. And be sure to check back for more episodes on important infectious disease topics. Thank you.